I was asked to talk about heart failure in the ambulatory patient. So we will talk about the definition, and this is based, again, the definition given by the people sitting and writing all these guidelines. So we'll use the same definition, which has been the same in the guidelines from 2009, and repeat in the more recent guidelines in 2013, but we will use their definitions to understand why we divide the patients the way that we do and why we treat them a different way. We will talk about the clinical presentation, the guidelines for evaluation of heart failure when the patient just goes through the door for the first time with complaint of some shortness of breath, stage of heart failure, and how much we would like to see you classified patients by stage and functional capacity, medical management. I will just touch on device because we will have Jill Jello coming on in June to talk about advanced heart failure, and I really strongly recommend everybody. She's great. She's from our heart failure group, so to come and listen to her for advanced. We are going to concentrate in patients with heart failure in the ambulatory setting. And then if we have some time, I wanted to bring you what I heard in the very last meeting a couple of weeks ago, because as you will see in the last years, not much has changed in terms of treatment of heart failure, medically speaking, and I thought that it's fun to review what's going out there and what are the new ideas about how to treat heart failure. Let's see if we have time for the new trials too. So this is the definition given by people sitting there and writing the guidelines. So heart failure is a clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject blood to meet the metabolic demands of the body. And I think that this is a fair classification because, as we will see soon, not everybody with heart failure has LV dysfunction. So the filling portion was already recognized long ago and was already described in 2009 guidelines and reaffirmed this time in the more recent 2013 guidelines. There is no single diagnostic test for heart failure because it is largely a clinical diagnosis based on a careful history and physical exam. And we will see that that's not easy in our population. So the main symptoms of heart failures are the consequence of congestion. So, the first step will be patient has a decreased exercise capacity, and this will be due to congestion. So that means worsening heart failure, which elevate the left ventricular end diastolic pressures, and if the left ventricular end diastolic pressures are elevated, that means more stress on the walls of the left ventricle, which in times can provoke dilatation of the left ventricle, increase of mitral insufficiency, functional mitral insufficiency, that will increase the myocardial oxygen demands, that will increase the myocardial ischemia, and again worsening heart failure. So when we enter the cycle of heart failure, it's a kind of a vicious circle that we need to cut in one point or another. So a little bit of the epidemiology to understand how important this disease is. Although the incidence has been stable over the years, the prevalence has increased because of our aging population. And the incidence is the highest in African American and the lowest African American men and the lowest in Caucasian women. But still, as I mentioned, prevalence continues to grow because of our aging population. And in fact, the long life risk of developing heart failure for people older than 45 is 20%, so, which is really amazing. So how much does it cost to us? A lot. There are more than 6 million adults with heart failure and almost 700,000 new diagnoses every year. And that represents more than 12 million clinical visits for heart failure in the United States. And over 1 million is hospitalized a year. Furthermore, 25% will be hospitalized again in less than 1 month, and 50% in 6 months. So that's an incredible cost of healthcare, and the largest contributor to the spending for unplanned readmissions, because those are the patients that get readmitted time after time. And this is why it's so important to be more aggressive in our clinical practice and aware about heart failure and try to avoid the decompensation and the need of admission. And as you see, heart failure is pretty malignant disease. When we compare that with cancer, it's even worse than ovarian cancer. It's pretty dramatic. So 50% of people will die in 5 years after the diagnosis. So this is a pretty malignant disease. Here is when we try to start to talk about heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction, or half RAF. We cardiologists like to say half puff, half RAF, but it's with preserved ejection fraction, reduced ejection fraction. So in patients with preserved ejection fraction, the main etiology is actually hypertension, when in patients with reduced ejection fraction is coronary artery disease. And symptoms, in general, the first symptoms that the patient will bring when he's coming to see you in the clinic will be a decrease in exercise capacity. They will complain that they can do less and less from day to day. But sometimes we see them in more advanced stage with edema, fatigue, weakness, PND, orthopnea. And then the signs, when we look at the patients, the most common findings are leg edema, elevated jugular venous distension, RELS, hepatomegaly, hepatojugular reflex, S3 gallop, and in more advanced, really advanced cases, pulsus alternans. But you can see here that neither symptoms and signs are extremely helpful, except for probably for the positive predictive value of jugular venous distension and edema. So most of the symptoms and signs have a pretty low sensitivity and specificity. So this is not surprising, especially when we consider our large population of obese patients, that they are very sedentary, that have COPD, smokers, and so far and so on. It's not an easy task to make the diagnostic of heart failure. So when we see for the first time this patient that comes and complains of shortness of breath with activity, or even orthopnea, PND, and we don't know if it's COPD, worsening COPD, CHF, or anything else. Of course, as it is everything in medicine, a good history and physical exam will be very, very important. But in congestive heart failure may be more important than in other circumstances, because in those patients we will have a direction. Knowing the history, we will have a direction in terms of what we do next, what can be the cause of the decreased exercise capacity. And sometimes, even if we think that it's just mainly COPD, it may be COPD, but now with a component of CHF, but at least we will have directions where to go from there. So, of course, after a complete historic and physical exam, guidelines say you need to have all, regular blood tests done, the more common ones, the routine ones. But to the routine ones, you want to add an A1C and a TSH. Of course, you need to have a chest X-ray, an EKG. But then, based on the history of the patient, we need to concentrate and order more specific tests. If a patient is high risk for HIV, then try to look into that. If the patient look that he may have hemochromatosis, then we want to look into transfer. But then, after all these labs are done, and after all the physical and all the history of the patient is finished, we still may not know if the patient has heart failure or not. So this is when BNP has a role, the specific role, to help us for the diagnosis of congestive heart failure. Of course, the most what I will say, the most useful diagnostic test is echo. And actually, echo will be the main study that we need to order in all patients with suspect heart failure, no matter what. First of all, it will, because it help us to divide patients with preserved versus reduced ejection fraction. But furthermore, we help us to see other possible causes of heart failure or possible causes of symptoms. For example, if all of the sudden we have a pretty normal LV function and no significant valvular abnormalities and no significant diastolic dysfunction, and we see that the patient has a severe pulmonary hypertension, for example, well, here we are, and we don't see any cardiac reason for severe pulmonary hypertension. So it's very important that we have the elements of the echo to start to look in one direction or another. Sometimes echo will allow us actually to see that the problem is maybe more of a constrictive disease, and that is easily, or not easily, but definitely able to be seen by echo. And if how many patients, and we are seeing more and more of these patients coming with constrictive physiology, patients at a younger age receive radiation, for Hodgkin disease or whatever, or women that 20 years back received massive radiation for breast cancer and so on, and then coming 20 years later and having sometimes pericardial disease, sometimes a male pericardial disease, and so forth and so on. But to allow us also to classify patients, we may see for the first time abnormal wall motion that will be in support of coronary artery disease, for example. In other words, echo should be our next stop to try to figure it out what's wrong with the patient and go from there. So what are the stages of heart failure? We have 4 stages. Stage A is patient at high risk for having disease, but with no structural abnormality. And stages are based mainly on structure and complaints, structure and symptoms, where functional capacity will be more a functional classification. So stage A, patients at risk. Who are these patients? Hypertensive patients, diabetic, obese, sedentary patients with metabolic syndrome, etc. All these patients are stage A. Stage B, patients with structural disease, could be LVH, valvular disease, LV dysfunction, but with no symptoms. Stage C is stage B plus symptoms. And stage D are refractory end-stage heart failure patients. All right? And I would like to, you to, every time that see a heart failure patient, to think about the stage 2, because stages go only one direction. They don't come back. So it's important to situate the patient in which stage the patient is. Our goal is to prevent progression, and this is why we need to be aggressive in stage A. Now we have the more common, popular classification, the New York Heart Association classification, that is related to functional capacity, class 1, no limitations with exercise, class 2, slightly limitation with exercise, class 3, significant limitation with minimal or lower level of activity, and class 4, symptoms at rest. So I would like to see you in your brains when you see a patient, classifying them in stage and functional capacity, because it gives you both, because class, we can go from 3 to 2 easily. We can go from 2 to 1 sometimes with good management of risk factors or with aggressive treatment. So guidelines decide that we should divide our heart failure patients with a EF concentric definition, an ejection fraction concentric definition. And why is that? It doesn't come because. It's actually because all of the proven treatment for heart failure is proven to be good for patients with decreased ejection fraction. It's an ejection fraction less than 40%. And this is why guidelines prefer to separate the patient with preserved ejection fraction greater than 50%, and reduced ejection fraction less than 40%. So, of course, as I mentioned, those with reduced ejection fraction, we have proven medical treatment. For those with preserved ejection fraction, we should treat risk factors, but we don't have any proven medical treatment that will reduce significantly mortality and readmissions with congestive heart failure, although it appears that aggressive treatment of risk factors, as we're going to see, may be helpful, but we don't have specific drugs. And then for the intermediate risk, it may be the same patients that were actually patients with reduced ejection fraction that with treatment went to a category of better ejection fraction with treatment. As we are going to see, that's very possible, and then fall in the 40 to 50%, which is the gray area. And I guess it's the gray area because nobody knows what to do with this patient. We treat a little bit for reduced ejection fraction. We treat a lot for preserved ejection fraction, being very aggressive with medical treatment to control risk factors. What's the difference between the common patient entering your clinic with preserved ejection fraction? Is in general an old lady, much more common old lady, hypertensive with other comorbidities including atrial fibrillation, obesity, sedentarism, chronic kidney disease, and left ventricular hypertrophy in the echo. Where a patient entering with heart failure with reduced ejection fraction is in general a middle-aged man with history of coronary artery disease, smoker, COPD, and usually in the echo, instead of seeing LVH, you will see a dilated left ventricle. But the presentation is equal for those. Both is congestion. So we don't know exactly what is the pathophysiology of heart failure with preserved ejection fraction, although there is a consensus that the main issue is left ventricular stiffness and impaired relaxation. So the heart really, and you see that in the older lady, which the cavity is small, a lot of left ventricular hypertrophy, and then a stiff heart that doesn't relax. But of course, there may be also, and there is more and more talking about maybe an abnormal left ventricular torsion and twist mechanism, an impaired chronotropic reserve and vasodilatation with exercise, left atrial dysfunction, and impaired myocardial energetics. It's probably a more complex process of just an increase in stiffness. No matter what, if you have preserved ejection fraction or not, your risk of die in 5 years is equal. It's very close. There is not much difference between preserved ejection fraction and reduced ejection fraction. So what the guidelines say for patients with heart failure with preserved ejection fraction? As I mentioned before, there is not specific treatment, but if a patient has heart failure and a preserved ejection fraction and hypertension, probably for this patient, you will choose to use as a first line for the blood pressure for this specific patient, ACE and beta blockers, because those are the drugs that are useful in reduced ejection fraction. So when you need to treat the blood pressure, you maybe will start with this medication, but you need to be aggressive with whatever medication you are given to control actually risk factors for heart failure with preserved ejection fraction. So of course, well control of blood pressure. If the patient has symptoms of congestion, For relief of symptoms, we will use diuretics, and we are going to talk much more when we go into congestive heart failure with reduced ejection fraction, but you need to use diuretics also if the left ventricular systolic function is normal, just if the patient is congested. Of course, you need to treat other things that may be going on and worse heart failure, for example, atrial fibrillation. If the patient are an atrial fibrillation with rapid ventricular response, they will go into the compensated heart failure. Furthermore, we just talked about the possibility that one of the components of diastolic dysfunction is also the abnormal function of the left atrium. So if the patient has, for example, paroxysmal atrial fibrillation, you may think in other options for controlling the paroxysmal atrial fibrillation. Can be medically treatment or maybe ablation even. So we need to see around all the things that may worsen heart failure and address one by one. Coronary artery disease, suspect coronary disease. We believe that perfusion will improve heart failure. We should offer that. So in each case separately, but looking at all possible causes of heart failure in the cases of preserved ejection fraction. So as I mentioned, in medical management, just everything that we say, management of lipid and blood glucose, of course, talk about concerning about tobacco, illegal use and excessive alcohol intake, as I mentioned, control of rhythms, and maybe put back a patient's sinus rhythm if we suspect that the patient has a thyroid disorder, treat the thyroid disorder, and so far and so on. Let's talk about patients in stage B, more concentrate now in patients that do have an abnormal echo. Stage B is symptomatic with cardiac abnormality. So class 1 recommendation apply for all stage A patients, meaning we need to control blood pressure, diabetes, hyperlipidemia, heart rate, thyroid dysfunction, stop smoking, stop drinking, and so far and so on. All the things that we have just discussed, we should implement in class B, of course, plus the addition of ACE or ARBs, plus beta blocker. In all patients with class B, regardless of the ejection fraction, patient has need to be on those two medications. Of course, for all of those, if they had an MI. If they didn't have an MI, then if the ejection fraction is more than 40%, each case will be separated. But everybody that had an MI and has a class B, by definition, with an abnormal echo, should be on beta blockers, ACE or ARBs. Of course, that is applied for every patient that has an ejection fraction less than 40%. And of course, treat, as we mentioned before, any possible other reason for dysfunction, as it will be valvular disease or coronary artery disease. No matter what, if our patient is congested from abnormal systolic or diastolic heart failure, the main issue again is congestion, and the way to treat congestion is by start diuresis. And the most commonly diuretic used are the loop diuretics. More commonly we use furosemide. So we need, and again, you should know that there are not many really randomized studies, large randomized studies showing an improved mortality or readmission, but definitely improved symptoms. And this is why we start with loop diuretics. Sometimes, despite starting loop diuretics, it doesn't help, and we need to add a second diuretic. In general, we prefer to use another class. In general, we like to combine loop diuretics with thiazides or thiazide-like diuretics like metolazone. Metolazone is an excellent diuretic in terms of everybody pees with metolazone. The problem is that it's not an easy drug to be given. Patients do show very significant electrolytes abnormality, including hyponatremia, hypomagnesemia, and hypokalemia. So if you start metolazone, you need to close follow-up this patient and expect that the kidney function will also be reduced. Use it with caution. So what are the integrated recommendations for diuresis? So when you see your patient for the first time with congestion, start loop diuretics. Loop diuretics, let's say furosemide 40 milligrams didn't help. You can increase first your loop diuretics, but don't double a single dose, but rather divide the dose in 2 or 3 times a day. Studies have shown that this is much more physiologic and much more effective than one large dose. If, despite increasing the dose, divided dose of loop diuretic doesn't work, you may want to choose torsemide, which is a little bit more potent loop diuretic. And if that doesn't work, think about thiazides or thiazide-like diuretics like chlorothiazide or metolazone, but try to avoid to use them as a long-term treatment, but rather short-term for the acute setting. And then maybe when the patient is getting better, we definitely can back off on this diuretic and go and try to find the baseline amount of drug that the patient may need to keep the patient euvolemic. Remember, if you start metolazone, remember to follow up on electrolytes. Now, we need to educate our patients, and we are going to talk a little bit more about that. So it's important to tell them, weight yourself, let us know if your weight is going up, call us immediately, don't wait. Obviously, if the patient is a little bit more engaged and more intelligent and we can trust the patient, we can even say, just when your weight goes up, add this little half metolazone or 1 metolazone and for 1 day and see what happens, instead of coming immediately and calling me. But there is a very selective population that we can do that. Let's talk about the ACE. In congestive heart failure, and this is full analysis of 32 randomized trials, just to show you that it works. ACE work and reduce mortality of all causes, mortality due to congestive heart failure, and rehospitalization in a significant way. So every patient with heart failure with reduced ejection fraction that doesn't have a contraindication for ACE should be on ACE. And this is the integrated recommendation. Again, for all patients with an ejection fraction less than 40%. But remember, most studies were done with high dose or maximal tolerated dose, I should say. No high dose, but maximal tolerated dose. So we don't need to feel happy with starting lisinopril 2.5 milligrams and say, oh, okay, the patient is on ACE, we are all good. No, we need to build up and push as high as we can the doses of ACE inhibitors, okay? So if the patient cannot tolerate ACE, of course, our second option is ARBs, which haven't shown, as we will see in a second, the same beneficial effect. What we don't do is to put them together. Studies didn't show any benefit of mixing ACE and ARBs, okay? And that's just to show that ARBs work as good at ACE, and both studies here, the candesartan and valsartan, show a significant reduce in mortality. What about the beta blockers? Beta blockers, the ones that have shown to decrease mortality and hospitalizations, are carvedilol, bisoprolol that we use very little in the United States, and metoprolol succinate. All three of them are good. You can pick whatever you want. all three of them have shown to decrease significantly mortality from heart failure in patients with reduced ejection fraction. But remember, and they improve also ejection fraction. Remember that I told you there is this group that may have been actually 35% or 40% ejection fraction, that now is 45 or 47. It may have been that we just put them in the right treatment, ACE and beta blockers, and then we see an increase also in ejection fraction. Those are people that actually were heart failure with reduced ejection fraction, but just moved to a better category because of our treatment. But remember, look at that. Improvement of ejection fraction is dose dependent. So the highest dose patient can tolerate, we need to remember to push also beta blockers to the maximal tolerated dose, which is the way that most large studies were designed. They continue to uptrade the dose to maximal tolerated dose. And if you look at the next slide, in fact, patients that have a lower heart rate at rest, those with a heart rate less than 72 at rest, are the ones that do the best in terms of reducing of mortality. So apparently being bradycardia as a consequence of the treatment that we are offering, as a consequence of the beta blocker, is a good thing, although you may be telling me, well, maybe patients that are not responding is because they are in the very extreme, being too sick to even respond to beta blockers. But definitely the fact is that those that have a heart rate less than 72 do better than those that have a heart rate at rest greater than 84. So what about aldosterone receptor blockers? Well, those are, and there is a small difference between the recommendation of the American Heart Association, American College of Cardiology, and the Heart Failure Society, but at the end of the day, they are pretty similar. If the patient already is on beta blockers, on ACE inhibitors, optimal dose, on diuretics, and still has significant symptoms of congestive heart failure and reduced ejection fraction, you can try aldosterone or any of the aldosterone receptor blockers. Remember, this patient needs to have a baseline potassium of less than 5 and a creatinine of less than 2 for women and less to 2.5 for men, and a glomerular filtration rate of higher than 30 ml per minute. Patients that have less than 30 ml per minute or a high creatinine are not candidate for aldosterone receptor blockade. They do indeed increase potassium, so the current recommendation is have a baseline potassium, have a potassium a week after starting treatment, and continue to have a potassium every 3 months. What about hydralazine and nitrates combination? Well, it has shown to be effective in people that are self-described African American. That comes from a very old study from the Veterans Administration from the late 80s, beginning of the 90s, but later was a little bit reproduced in other studies. So apparently it does work, especially in the African American population, but it's an option in patients that cannot be on ACE due to advanced kidney dysfunction or other reasons, ACE or ARBs. And in patients that they are already on all the above and still have symptoms, if they have enough blood pressure and room to try this drug, we can definitely add and see what happens. What about digoxin? Digoxin has shown to reduce a bit readmission, but it doesn't do a thing for in terms of survival. But you know, it may improve symptoms, and this is what we want for our patients to feel better. Digoxin is especially good in patients with atrial fibrillation with rapid ventricular response when we are already maximum tolerated dose of beta blockers and they still are fast and we don't have any room to push any more beta blockers because they are hypotensive. They get orthostatic hypotension and so on and so on. So So it's a good option for this patient. But remember, the Heart Failure Society recommends a low dose of digoxin. In fact, they said that most people are good with 0.125 milligrams a day. So, and we want the digoxin level to be less than 1 nanogram per milliliter. As I mentioned, it's the best for patients with atrial fibrillation where we can't push more beta blockers. So just to summarize what we said so far, if you have a patient in class C, remember class C is symptomatic with structural disease. So you have a patient in class C, start with ACE or ARBs and beta blockers. If that's not enough, add a loop diuretic. If it's not enough, you may consider, especially if your patient is an African American, hydralazine and nitrates. If that's not enough, add aldosterone. But remember, with aldosterone, potassium less than 5, creatinine less than 2 for women, less than 2.5 for men, and a GFR higher than 30. Remember that there are drugs that worsen heart failure. And actually, I start to routinely ask all my patients with heart failure that come and visit me, and all of a sudden they increase the weight. Of course, I first thing ask about the diet. They went a couple of nights in a row for a Chinese food, and then they come. But the most common thing that I found is that patients start to take high doses NSAID without telling us. They go over the counter, they buy, they have a little hip pain or whatever, and they are on high dose NSAID. And remember, NSAID can cause sodium retention and peripheral vasoconstriction, and attenuate the effect and enhance the toxicity of diuretics and ACE. So remember specifically, I do that, and I find so many times that my patients are actually taking over the counter NSAID. So I routinely ask my patient if they are taking anything over the counter that didn't tell us. Of course, we try to avoid the calcium channel blockers, except for the vasoselective ones, and antiarrhythmic drugs, except for amiodarone and dofetilide. All of them can worsen heart failure. What if our patient is in stage D? And I will not enter the treatment of stage D because, as I mentioned, Jill Jello from the heart failure group will come to talk about advanced heart failure and what we can offer our patients. But just to check into the fact that there is a time when we say enough is enough. An older man that is not anymore an older woman, which is not a candidate anymore for advanced therapy, as it will be transplant or it will be a left ventricular assisted device. We can discuss hospice. We can discuss with this patient also if they already have an ICD to disconnect, to turn off the ICD, just they don't get shocked. And it's an acceptable conversation that we need to have with our patients. For the others that they are good candidates, we should refer them to a heart transplant center. They can get in the list for heart transplant and maybe have a left ventricular device. For patients, obviously, that have a life expectancy of more than 1 year, that is greater than 50%. Otherwise, there is not much that we can offer. And again, the assist device can be offered as a bridge or destination therapy. What about anticoagulation for patients with congestive heart failure with left ventricular dysfunction, ejection fraction less than 40%? We should not routinely use anticoagulation except if there is another indication for anticoagulation, as it will be atrial fibrillation or history of thromboembolic events or really a cardioembolic surge of stroke or so and so on. Otherwise, it's not a routine therapy for our patient. Of course, aspirin will be indicated in patients that have non-CAD, not exactly for patients that have, for example, idiopathic cardiomyopathy. So just touching here what we can offer for advanced heart failure, still in the ambulatory setting, when you see these patients that have reduced ejection fraction, that they're doing okay with treatment, but they, despite the treatment, continue to have an ejection fraction of less than 35%, and class 2 symptoms, so those patients have a class 1 indication if they are class 2 or class 3 symptoms for an ICD if they have an ejection fraction of 35% or less and they are already on optimal medical therapy. So we can offer an ICD to prevent, for primary prevention, to prevent death from arrhythmia. It's a class 2A indication in ischemic cardiomyopathy more than 40 days after the acute MI, because one study showed that actually ICDs in the very first, immediately after an acute MI show no benefits. So it need to be 40 days after the acute MI if the ejection fraction continued to be reduced, and in this case they choose 30%. But even if they are asymptomatic, we still can offer an ICD to prevent death from ventricular arrhythmias. Biventricular pacing, where we try to, in patients that have complete left branch block with a wide QRS and have desynchrony when the heart is contracting, so we can offer them a biventricular pacing, trying to improve the synchronization of the contraction, and in fact studies have shown that does increase ejection fraction. The ones that benefit the most are the ones that have wide QRS, although the guidelines say at least 120. Studies have shown that the ones that do the best are the ones that have 140 milliseconds and more. And of course, we need to address these issues with our patients, as I mentioned before. Adherence with medication, with diet, tobacco cessation, weight loss, and I am happy to announce now that Medicare approved as heart failure, stable heart failure, as an indication for referral for phase 2 cardiac rehab. So starting this year. So patients that have, but they need to have an ejection fraction less than 35%. So we can't send yet, and I don't know why, we can send yet patient with diastolic dysfunction. It's only for patients with systolic dysfunction. But if the ejection fraction is documented to be 35% and the patient is stable, Medicare now pay for phase 2 cardiac rehab, and we have the best cardiac rehab here, so please feel free to send your patients for cardiac rehab. It has been shown that really help readmissions, and of course our patients feel much better when exercise. So remember that our patients have dealing with many other issues that probably need to address, because all of the things on the right side are markers of worse prognosis. Well, aging, I guess you don't have much to do with that, but all the others should be addressed, because all these may be just markers, but all of these are markers of bad prognosis, and probably if we can address and improve, especially the depression, and the problem with literacy, not taking the correct drugs, etc. All those are markers of bad prognosis. Let's see. I think that we have a few minutes to review the trials, because it's fun, As you notice, all what I said is not much new in terms of medication using for heart failure. Maybe put more in guidelines saying this is the numbers, this is what we know, this is what we don't know, how it works. But interesting enough, there are a lot of things there trying to, a lot of research done in trying to improve our treatment of patients with heart failure, especially because, after all, it costs us fortunes, and because at the end of the day, 50% of your patients, for the moment that you diagnose them with heart failure, will be dead in 5 years. So more and more work trying to find a good treatment for these patients. And I mentioned that probably the most problematic of all is the patients with diastolic heart failure, because we don't have no therapy, specific therapy to offer them. Rather, what we do is actually treat all the possible causes for diastolic heart failure. So the RELAX study is a study done with Viagra, actually. The rationale for choosing Viagra is that evidence suggests that activated phosphodiesterase 5 may limit beneficial action of nitric oxide and natriuretic peptide in the heart, vasculature, and kidney. So they thought that if we block that, then the patient will do better. The results were very negative, very negative. So patients that got Viagra actually did much worse, including kidney dysfunction. So I don't think that we are going to hear more about this approach. It's done. So all of the other, unfortunately, are on systolic heart failure. Maybe they were much happier, but not better.
What dose did they use of Viagra?
Oh, they use very high dose.
Very high doses.
Mm-hmm. Yeah. So systolic heart failure. Astronaut study, renin inhibitor, was borderline negative study in terms of using the renin inhibitors in the whole group as a whole, and that was a large study that recruited more than 1,000 patients. But about 30% of them were diabetic, and that brings down all the results. So it was the diabetic group that did really bad, and for that, the whole final numbers were in general bad. But in a pre-specified group of non-diabetic patients, there were some signs that that was a positive study. So in diabetics, it worse renal function, increased mortality, and that's not to expect, since diabetics have much more kidney issues going on and much more risk of having high potassium level using the renin inhibitors. So I think that we will listen a little bit more about Alice Keating further studies, but it will be only in patients with no diabetes. We'll see what happens. The RED heart failure study, treatment of anemia in chronic systolic heart failure with erythropoietin stimulate agent. In this case, they use darbepoetin alpha. You know, anemia is a marker of bad prognosis. So already in the past, people thought that if we fix anemia, we may improve mortality. Although I'm not sure why they thought that way, because a previous study in patients, given patients with anemia, blood transfusion, didn't show any benefit, which make us think that anemia is just a marker of bad prognosis, and addressing that marker will make no difference. To make long story short, this is also a pretty large study done in more than 2,000 patients. It was negative, patients that received, and they choose actually, I was surprised that they choose patients with mild anemia, with an hemoglobin between 9 and 12, to keep an hemoglobin in the 13 range, between 13 and 14. And it was a negative study because of more incidence of thromboembolic events. So I guess we are done. We tried transfusion, didn't work. We tried erythropoietin stimulate agents, doesn't work. We probably need to try to prevent the anemia in other ways. I mean, treating more aggressively and so on than anything else. The SHIFT study, this is with ivabradine, and ivabradine is a medication that is available in Europe and has been approved there, but FDA didn't approve this drug here, and I'm not sure why. In any case, it has been in the market for a while for the treatment of angina in Europe, because it's an IF channel inhibitor, and the IF receive only in the sinus node, and there is some in the retina. The sinus node, there is not in other place on the heart, not in the AV node, not in the heart muscle anywhere, just in the sinus node. So what it does is just reduce heart rate, nothing else. So it doesn't reduce blood pressure, it doesn't make any hemodynamic changes whatsoever, just the sinus node. So remember that I show you the slide that says that people with a low heart rate do better, no matter what, do better than people that have increased heart rate. So they recruit for this study more than 6,000. It's a large study. 6,000 patients that divide into groups, one placebo, one with ivabradine. And what they notice actually is that, and they give on all patients that were already on beta blockers or couldn't tolerate beta blockers, they add ivabradine. And what they found is actually that the group that got ivabradine had a relative risk reduction of 18% for death. So, and death and hospitalization. So, pretty promising, especially because it's very well tolerated. People don't get hypotensive, and it can be a solution for all our patients where we can't push beta blockers because of the side effects of hypotension. So keep tuned for this one. This one will come back, and there were more than 300 centers, but none of them in the United States. So I guess until we don't have an hour of research, it will not be approved by the FDA. And this is probably the most exciting of all of them, the Relax AHF, not like the first Relax, it's the Relax AHF, which is serelaxin in patients with acute heart failure. And serelaxin is a recombinant from human relaxin 2, which is naturally occurring in us, but especially during pregnancy. We have very high level of relaxin 2 during pregnancy, which apparently are the mediators of our physiologic changes during pregnancy with higher cardiac output and all the adaptation that we have during pregnancy. So they actually did this study giving patients that are admitted with heart failure, given serelaxin, and the results were pretty promising long term. I mean, dyspnea improved in all patients, but actually at 6 months was also a combined 38% decrease of all cause mortality, but no composite secondary endpoint of readmission at 60 days. But, it's a good deal. If you live more, even if you're readmitted, that's a good deal. And more important, serelaxin favorably affect all markers. When they check the natriuretic peptide and other markers, they were all better in people that got serelaxin. So I guess we will be hearing more and more about serelaxin. And that's it. So thank you for your attention. And if you have any questions, feel free to ask.
So I'm trying to push my ACE and I'm trying to push my beta blocker. When I run into a wall, which one do I quit pushing first?
Good question. It's very depending what is, for example, the heart rate of the patient. If the patient is already under 70, push your ACE. Don't push your beta blocker. If your patient is still tachycardic, back off with the ACE in favor of the beta blocker. I think he has a
Okay, a lot of questions. BNP, what's the niche for BNP? When it came out, it was the greatest thing since sliced
right. And as you see, I didn't talk a lot about
well,
BNP.
you said that when there's a question about the diagnosis CHF, you may use BNP question mark.
Yeah.
So should we just throw it out and discard it and say it was another passing fancy, or
No.
a niche?
No. There is a huge niche for BNP, but it's probably more related, to inpatients. Studies have shown that has a value as a prognostic measurement, has a value on the same patient for treatment, has a value, of course, for patients where the diagnosis is unclear, and we have so many of those. Patients that come huffing and puffing, and they are obese, and with my best efforts, and I consider myself a good clinician, I can't see the have any JVD or not. And I don't know if they are COPD, they are entering with smelling smoke all over. So you don't know if that's COPD. And they don't move, they have swelling, and they are this big. So I think that, but remember, those patients may have a BNP of 150 or 120. And especially if they're older, 150 may be normal. So it's not really always helpful, but if all of a sudden I get one of 3,000, oh, well.
Or over 500, I heard.
Or over 500.
Over 500
yeah. Well,
consistent
then I
CHF.
think that, he's huffing and puffing. It's not only COPD, obesity, sedentarism, and so far and so on. So there are some, and of course, in research terms, of course, I mean, everything that we want to measure, especially in the new, when we are looking into the new studies, is super important. Pro-BNP, especially terminal end pro-BNP measurements, on all these studies and so on and so on. So I think that it is a role in the clinical practice for your patients, in your patient. Maybe a role to see how the patient is doing with your treatment. You have your baseline, you treat. You don't know because the patient continues to be equally sedentary, though you now can send him to the cardiac rehab. But the patient decides not to go, decides not to lose weight, decides not to do, and you don't know how much to push because your clinical judgment is that he may be better. But he says, doctor, I feel the same, but you don't see much ABD anymore. So you may want to recheck in the same patient because it's in the same patient that you are going to see the result. But remember, studies have shown that patients that have higher BNP have worse prognosis. So I think that has a role. I'm not sure that it should be routine in every single that comes walking and has a little bit of shortness of breath. So what do you think, Scott?
Well, I was on a consult service a couple weeks ago, and my challenge at the beginning of the service to the residents and medical students was finding a BNP that makes me change my decision-making based off of everything else I know. And in 2 weeks, we didn't find that. We did a lot of searching for it. Other people drew it. I think it has a clinical utility, like Diana said, in the etiology, in the emergency room, or in the clinic when you're presenting with dyspnea. That's well documented, that it can help shift you one way or the other. And then I think it has important prognostic information about it that you can, that is undeniable. In the person that comes in who already has one elevated in the past and has heart failure, and their BNP is 1,000 and now it's 5,000 and now it's 500, it has absolutely no clinical utility whatsoever. None.
So if there is a normal BNP, is that meaningful? Is that kind of like a zero calcium?
No, sensitivity and specificity is not as high as calcium score of 0, actually.
So you can have a normal BNP and have congestive heart failure?
And you can, especially if you are young.
So really it's not a rule-out type of method?
Not really. You still can have a young person that comes with a BNP of 90, and he has JVD. For me, he has JVD. For me, he has symptoms. For me, it's congestive heart failure. And then I do an echo and see that the patient indeed has diastolic dysfunction and so on. No?
His normal BNP might have been 5. So
Exactly.
So you don't actually know. I got a question about LVH, diastolic heart failure. I did not realize that the prognosis is equally as bad as systolic. So we see a lot of patients who are hypertensive, older, who have LVH, and I read one study that said that ARBs are actually superior to ACEs. You seem to suggest that they're totally interchangeable. Is there any data that supports preferentially using an ARB rather than an ACE in someone who has LVH and diastolic dysfunction and normal EF?
Not that I'm aware of.
No?
Are you?
No?
No.
So
it may have been a small study. There are all the time small studies reviewing the guidelines, and I have reviewed all guidelines from the Heart First Society and the American College of American Heart Association in preparation for this talk. Also, I tried to review all large studies. I haven't found any serious study that was considered into the guidelines for such a thing. And when you read them, both societies agree that no, there is no difference. And in fact, your first step of order should be ACE, and only if they are not tolerated, go to ARBs. So, do you know about anything?
No, I think if there were any postulated improvement, it would be in degrees of fibrosis and things like that. So then you're looking at the sub.
Remodeling and that sort of stuff.
Yeah, but probably
There's no difference in outcomes that I'm aware of.
Mm-hmm.
And, when medications are expensive, and we have generic ones that are efficacious and keep people alive, we owe it to them and the community at large to utilize the best proven ones for outcomes.
You said metoprolol succinate. I'd seen that there's another metoprolol preparation.
tartrate, yeah.
Yeah, but that is not useful.
It has
Succinate
not been actually studied the same way succinate, and actually the studies where they were compared, they were kind of unfair, I think. You may think different, but people were given a fixed dose of metoprolol tartrate and was lower in terms of, they didn't go for maximal tolerated dose when they were compared head by head. So, as Scott just mentioned before, we care very much about our patients' economics too. Succinate is not a $4 a generic. I personally, for people that need to pay out of pocket medication, I do tartrate just because it's so much cheaper, and I know that they will take them if they can afford. They will not take either of them. If I prescribe succinate and they can't afford, they will not take, period. They will not come and tell me, hey, maybe if you want. Most people will not refill the medication or not buy. So if I know in advance that the patient may not be taking succinate, I go for tartrate. What do you do, Scott?
Well, I have a bias because I see a lot of insulin-resistant diabetics and hypertensive individuals.
And you are going to talk about
that. I will utilize carvedilol above and beyond metoprolol any day of the week. So that's my own.
And it's his bias because I do exactly the opposite, probably because I do not so much care about.
But just from a congestive heart failure point of view, there's no data that supports one over the other, carvedilol or the three that you mentioned.
But the reason why I use metoprolol succinate is because my patient with carvedilol, high-dose carvedilol,
Expensive.
carvedilol is generic.
Oh, it's generic.
It's generic, yeah. So they have much. Personally, I see people complaining much more. They're more hypotensive than patients on succinate. But this is also my own bias. So it's not based in any evidence base.
So I've got a patient that's dyspneic. I sent them for the echo. I find out they have congestive heart failure. Get them stable. 6 months later, they have an exacerbation. I treat that, and maybe 2 months later, they have an exacerbation. Do I need to get another echo?
Good point. Very good point. So guidelines say, as long as the patient is stable, you don't. If the patient has an unexplained change, you do. So if the patient comes and says, well, see, I was just eating the last week every single day Chinese, and I didn't take my medication because I ran off my medication and I didn't have time or was too drunk to go and refill my medications or whatever, then there is no point in repeating the echo. But if you know that the patient is compliant and is doing the right thing, definitely there is a room for a repeating echo every time. And this is what guidelines say. It's indicated when a change has happened that cannot be explained.
I'm sorry, with someone with diastolic heart failure, with atrial fibrillation, should we attempt rate and rhythm control?
Very good question, and it's very individual. I personally think that rhythm control is important in patients with diastolic heart failure if I don't have other reason for the diastolic heart failure. I mean, in terms of the patient may have LVH, but his blood pressure is beautiful control. I don't have more room to push medication. I think that because there is a great support that atrial dysfunction may contribute to diastolic dysfunction, I prefer my patients, and interesting enough, I have this small group of patients that every time that they go into atrial fibrillation, even if they are not very fast, they go into heart failure. Interesting enough. There are others that don't see the difference. I mean, it's the same. But this specific group, I try to keep them on sinus, definitely. Any other questions? Yes,
For the
Megan.
ones that have AFib and have heart failure, are any of the newer, besides, do you recommend, Xarelto versus, Coumadin, or, have you noticed any difference between which works better for them?
Mm-hmm. Very good questions. So I think that they're all, in terms of efficacy, they're all good. Warfarin and all the new non-vitamin K drugs, but we need to think about the cost of these drugs and the compliance of the patient. So warfarin is good if you follow up and if you have a therapeutic INR. The other drugs, you don't need to follow up. There is good and probably are good for patients that can afford the insurance pay for that. I, in general, have a discussion with every single patient that needs to be started on warfarin or non-vitamin K anticoagulation, have the discussion, a personal discussion with each patient. I don't think that there is one better than the other at this point to push one direction or another. That's my personal opinion. What is your personal opinion?
Let's see. Okay, so dabigatran twice a day was the first one that came out. Then there was, I think, apixaban is once a day, and levodopa.
No, apixaban is twice a day, rivaroxaban is once a day.
I like apixaban.
I like apixaban because it's the one that has less side effects.
Yeah,
That's my
lowest GI bleeding.
yes, low GI bleeding, no GI complaints. But that's again I don't use dabigatran. I don't use dabigatran because patients complain so much about GI. Younger people don't love the idea of taking once a day, so rivaroxaban is an option.
What's the brand name of that one?
Huh?
What's the brand name of that one?
The apixaban is Eloquest, and rivaroxaban is Xarelto, and the dabigatran is Pradexa.
So you don't like that?
I don't like Pradexa, but just because patients complain of, but this is not based in any evidence base. It's my own bias.
Because of what you're doing?
Yes, and because I was using a Pradexa much before than the other two because they came later in the road. So I was so amazed by the amount of patients that complain of GI that I thought, well, we probably will never change from warfarin because there is so much GI complaints. But then came Xarelto and Eloquest, and interesting enough, people tolerate it very, very well. But I agree with, in my personal observation, the apixaban is the one with less GI bleeding.